Hello friends, welcome to Unacademy. I'm Dr. Shonali Chandra, and in today's video I will be talking about understanding fertility and the various causes of infertility. I have highlighted my reference code here, that is SHONALI, that's my name, and if you subscribe to the platform using this code, you can avail a 10% discount on your subscription. Now, the platform is Unacademy. It is India's largest learning platform which gives you access to unlimited live and recorded sessions from India's best educators. You'll get daily live classes where you can interact with your educator, ask your doubts and queries, get them solved there and then. So it's like a live classroom experience. The courses are structured keeping in line with the latest NEET PG syllabus. There are also live tests and quizzes which will help you evaluate your performance as you go. And most importantly, unlimited access is what you gain by getting a subscription, so you can watch all of the live sessions from all of the faculties who are on the platform. And even if you miss out on the live sessions, you can always go back and watch the recorded versions from the comfort of your own devices. Top educators are associated with the platform like Dr. Nikita Nanwani, Dr. Preeti Sharma, Dr. Mohammad Azam, Dr. Devesh Mishra sir for pathology. All 19 subjects which we need to prepare for the examination are covered on the platform. And apart from that, every now and then batch courses and short duration, concise crash courses, they keep getting launched. So you can check out the ongoing courses on the platform as well. And as far as the subscription packages go, you can choose depending upon your needs and requirements. So you can take the 3-month subscription, a short duration 6-month subscription if you want a crash course, or even a 12 months or a 24-month subscription. So if you ask me, for those of you who are targeting the next year mid-year exams, they can take the 12-month subscription here because it will give you ample time to go through all of the sessions and even leave you enough time in the end to revise. And it turns out to be more economical also in the longer run. And for those of you who are wanting a slower pace of preparation, who are still in their third years and final years, so of course you are juggling hospital schedules and duties at the same time, so you can take this 24-month subscription here. It turns out to be far more economical in the longer run. And if you subscribe using my code, that is SHONALI, then you can avail a 10% discount on your subscription as well. So coming back to the discussion at hand on understanding fertility and infertility. So let's get started. What is fertility? Well, the ability to conceive a pregnancy is what we call as fertility. Now, we all know that fertility requires both male and the female partner, right? So the evaluation of infertility has also to focus on both male and female partners, right? So we need a healthy sperm from the male partner, a healthy egg from the female partner. Both of these are haploid. The egg and the sperm are haploid. They have half the chromosome number. Then they are going to fuse together, fertilize, and we are going to get a diploid zygote, and that's your pregnancy there. But that's not all, And what then is infertility? Infertility is simply the inability to achieve a pregnancy. The inability to conceive is what we call as infertility. Now let us develop an understanding of how everything in the male and the female body is brought about to bring about fertility, right? So each month, in a regularly timed manner, the woman's body prepares to achieve a pregnancy, and primarily the reproductive organs. So the uterus and the ovaries are all set in motion, right? Each month this happens. What happens is that the healthy egg is released during the menstrual cycle. And if you remember, we had discussed in the previous sessions here, so just a recapitulation of that, in the menstrual cycle, in the first half of the cycle, so in a regularly cycling woman who has, for example, approximately, let's say 28 28-day cycle. In the first half of the cycle, what is happening is the follicles are growing. Then on the 14th day somewhere, the ovulation takes place. The egg is released. It is captured by the fallopian tube. What is left of the follicle becomes the corpus luteum, right? So in the first half of the cycle, the estrogen is getting produced. In the second half of the cycle, we are getting progesterone. So both this estrogen and progesterone are causing building up of the endometrium. So estrogen causes the proliferation of the endometrium. Progesterone causes the secretory changes in the endometrium, ultimately leading to building up of the endometrium. So creating this bed onto which the pregnancy will be received, right? So this happens in a cyclical manner every month, and that's not all. What we need is also a good number of healthy motile sperms, because ultimately when the semen is deposited in the woman's vagina, right, some of the sperms are going to be lost to the outside in the process. It's a long journey upwards. Some of the sperms are lost in the uterine cavity, some of the sperms are lost in the vagina, and only a few successful ones here are going to get the journey completed and are going to reach the fallopian tubes. So it is the fallopian tubes which are the site of fertilization. So fertilization is when the sperm enters the egg and the female of the egg nucleus and the sperm nucleus takes place. That is what we call as fertilization, and the site of this fertilization is the ampulla of the tube. Now, very interesting point to note here is that the fertilizable lifespan of an egg is only max to max about 24 hours, and the fertilizable lifespan of the sperm is max to max about 72 hours, right? So what do we get from that? What we get from that is the period of maximum fertility is around the time of ovulation. So in a month, the period of maximum fertility is around the time of ovulation. In fact, most of the pregnancies conceived, most of the fertilizations achieved, they happen when intercourse happens 3 days prior to and on the day of ovulation. So around that time is the period of highest fertility. Now, what is a healthy egg? What is a healthy egg? Now, this healthy egg comes from healthy ovaries, all right? Then the next thing that you need to remember here is coming back to our embryological discussion. So when a woman is born, you see, she has a finite number of eggs. Those eggs are contained inside the ovarian follicle. Now, this egg is what we call as the primary oocyte, which is diploid. It has the double set of chromosome there, right? Now, this primary oocyte is arrested in the diplotein stage of prophase of the first meiotic division. Now see, this is diploid here, primary oocyte. We need a haploid egg. For that, meiosis has to take place. So this primary oocyte is initially arrested in its development, and what is going to happen is at the time of ovulation, during the time of ovulation, meiosis 1 is completed. Meiosis 1 is completed, and we get a haploid secondary oocyte, and the first polar body is released. Now, this happens at the time of ovulation. Ovulation requires normal functioning hypothalamus, pituitary, and ovarian axis. So, we need adequate amounts of follicle stimulating hormone which are coming from the anterior pituitary to promote follicular growth. We also need adequate amounts of luteinizing hormone, which is again coming from the anterior pituitary, and we need it in the mid-cycle time. We need it mid-cycle so that ovulation can occur. It is the LH hormone that triggers ovulation, and it is that hormone which is going to trigger this meiosis 1 to get completed. All right, this is a very important step that is achieved during the time of ovulation. So ultimately, we get what we call as a chromosomally normal oocyte, isn't it? We get a healthy follicle which is synthesizing adequate amounts of estrogen so that a good uterine bed can be built up, right? We need a healthy corpus luteum which secretes adequate amount of progesterone to again bring about the secretory changes in the endometrium. And it goes without fail to say here, if there is no ovulation, there is no egg, and there is infertility. So all of our causes which are leading to an ovulation are going to contribute to infertility. And another very important thing that I want to talk about is the ovarian reserve. Like I told you a couple of minutes ago, that women are born with a finite number of eggs. So that means finite number of follicles are present in the ovary. Now, each month when a single egg ovulates, a number of follicles which are present in the ovary actually die. For each egg released, approximately about 1,000 follicles are undergoing atresia. So with each passing month, with each passing year of our reproductive lifespan, women are losing their eggs. So this ovarian reserve, which determines what is the residual number of follicles remaining in the ovary, declines with age. So it declines with increasing age. Don't get worried. That decline is quite rapid after the age of 35 to 40 years of age. That's when the decline in ovarian reserve is rapid. And something that I like to tell you, smoking is one thing that really damages the ovarian reserve. So smoking is a complete no-no. And so ovarian reserve, when it declines, also results in decrease in fertility. That's one thing to note here. Taking the journey forward, taking the journey of fertility forward, the egg has been released, it has been captured by the fallopian tube, it's there inside, and the semen is deposited in the vagina, right, by the act of coitus. Now, the sperms are going to ascend up into the uterine cavity, finally reaching the fallopian tube. And that's why I told you that sperms are required in adequate numbers. So millions of sperms are present in the per ejaculate volume, right? And out of those millions of sperms, some thousands only manage to reach the fallopian tubes. Now, one thing that is very, very important is that how do these sperms reach up? So they go up by virtue of their own motility. Very, very important. The sperm needs to be actively motile with a forward motility. They don't have to have the circulatory motility. That's wrong. They have to have forward motility. They need to climb up. So this motility will depend upon the structure of the sperm. Isn't it so? So the sperm needs to be motile. It needs to have a healthy tail, which is going to beat like a flagella and give it motility. There has to be a mitochondria, which is going to give the energy for the movement of the sperm. And finally, the sperm also has an acrosomal cap, about which I'm going to be talking about further on during fertilization. So sperm essentially has to be morphologically normal. Looking wise, structure wise, it should be normal, right? And very important, again, an important point to note here is that any male factor which is going to interfere with the physical act of coitus, like it could be a psychogenic impotence, it could be a drug-induced impotence, it could be a premature ejaculation, or it could be any factor which interferes with the physical act of coitus, any male factor that is going to affect the quantity and quality of sperm is going to indeed contribute to infertility. So here lies the contribution from the male partner, right? Now, other than that, you have to also understand, I told you that the period of maximum fertility is around the time of ovulation. So around the time of ovulation, the woman's system also helps the ascent of sperm. So like give them some assistance. So that assistance comes from here at the level of the cervix. This is the first resistance also, and this is where the first assistance also comes. So during the timing of around the time of ovulation, the cervical mucus becomes very thin and stretchable, a phenomena that happens because of the high amounts of estrogen during the time of ovulation, and this is phenomena is called as spin barky. Now, because the cervical mucus becomes thin and stretchable, the sperms can easily penetrate through the cervical mucus upwards into the genital tract, right? So any genital tract infection which is going to make the cervical mucus thick, excessively thick can provide hindrance to the ascent of sperms. It's going to interfere with that. Cervical stenosis, if there is a cervical stenosis because of fibrosis in this area, the fibrosis could have been a result of a history of prior dilatation and curettage, and there could be many factors for that. It could be infective, it could be congenital, whatever be the reason. If there's cervical stenosis, it is going to provide a mechanical hindrance to the ascent of sperms. Any uterine factors like submucosal fibroid. So you can have a growth here, a tumor of the myometrium here, and if it is invading into the endometrial cavity, that's called a submucosal fibroid. So that can also provide mechanical hindrance to the ascent of sperms, and all of these factors, can, what we say, contribute to infertility eventually. So these are the uterine factors, these are the cervical factors which can contribute to infertility, there are the male factors which can contribute to infertility, and further down the line, the journey of conception, the journey of fertility is not yet complete. The sperms have to move up into the genital tract, and there the sperms gain the capacity to fertilize, they gain hypermotility, which is called as capacitation. This is an extremely important step. It takes place in the female genital tract. Now, this part of maturation of the sperms, that is capacitation, takes place in the female genital tract. It begins in the cervix, but the major part of this capacitation occurs in the tube. It takes approximately about 7 hours of duration. So this capacity to fertilize and hypermotility is extremely important, because see, these sperms have to drill inside the egg, right? So that journey is still left. So let's have a look at there. What happens during fertilization is, you can see here that a number of sperms, reach the vicinity of that single egg, right? And when the egg is released into the fallopian tube, it is still surrounded by these cells, which are the corona radiata. These are the granulosa cells which still surround, some of the granulosa cells still surrounding the ovarian follicle. This is called as corona radiata. And there is also this thick acellular membrane that is covering the oocyte, that's called as the zona pellucida here. So the sperms need to penetrate this layer of the corona radiata. Ultimately, it will be able to reach this zona pellucida, and once that has happened, the sperm binds to the zona pellucida. That triggers an acrosomal reaction, and the acrosomal reaction causes release of enzymes from the acrosome, which was the cap on the sperm head. That was the acrosome there. So we can have a look at this figure here and see that the sperm is binding to the zona pellucida. This bright orange line here, that's the zona pellucida. The acrosomal reaction takes place after that binding. The enzymes present in the acrosome, like the acrosin and the hyaluronidase enzyme, they are released. They help to digest the zona pellucida, okay, those enzymes, and that is how the sperm is able to drill its way through into the zona pellucida, and finally the sperm is going to bind eventually to the oocyte membrane as well. So this release of enzymes, triggers then the penetration of the sperm across the zona, and once that happens, there's going to be fusion of the sperm with the oocyte membrane. And what that will trigger is very interesting to note here, because see, eventually we want a healthy zygote, don't we? We want a diploid zygote. So the sperm is half the chromosome haploid, the egg is half the chromosome that is diploid. We want to fuse them together and have a diploid zygote. But the important thing is, we don't want more than one sperm to fertilize the egg, do we? No, we want a single sperm to fertilize the egg. So for that, what happens is, you can see here these small granules that are arranged around the around this area of the oocyte. This is what we call as the cortical granules. So fusion of the sperm with the oocyte membrane, fusion of this sperm with the oocyte membrane triggers a reaction which is called as the cortical reactions, which brings about the release of calcium ions from these cortical granules, and that changes the structure of the oocyte membrane. That another reaction that is triggered is called as the zona reaction, where this zona pellucida is going to harden up. All right, that is called as zona hardening, so that once one sperm has been able to achieve penetration of the egg, other sperms which are in the vicinity or in the process of drilling, they are not able to penetrate the egg, and that's how polyspermy is prevented. That's how polyspermy is prevented. And another important event that takes place during the time of fertilization is, remember this secondary oocyte? Remember this egg that has been released? This egg that was released is the secondary oocyte, which is arrested in the metaphase of the second meiotic division. And this meiosis too is completed during the time of fertilization. So further maturation of the egg is achieved once the fertilization gets completed. Once that is done, meiosis gets completed and we get a mature egg. Now this mature egg is going to finally fuse with the male pronucleus. So fusion of male and female pronucleus, we are going to get a complete fertilization is going to be achieved, and that is what happens here. This is the whole process here. This is the whole journey that's get completed. Let's take the journey forward, because that's not all. Ultimately, to achieve a healthy pregnancy, it needs to be present in the uterine cavity. It needs to find its ground. So what we have got is here is a zygote that has been formed. This zygote is going to undergo cleavage, right? And it is going to form a morula. So simultaneously development of the early conceptus is also taking place, right? We have this corpus luteum here, as we can see, once the egg has been released in the second half of the cycle. Now, the important thing to note here is what is the role of the tube in all of this? So yes, ovum capture, right? That's the role of the femoral ends of the fallopian tube. Tube is the site of fertilization, and very, very importantly, this conceptus has to move into the uterine cavity, and that is facilitated by the action of the fallopian tubes. Now, these fallopian tubes, they have peristalsis-like activity. They have cilia beating towards the uterine cavity that helps in the movement of the conceptus towards the uterine cavity. And finally, the tubal secretions, the tubal epithelium also leads to secretions which are going to nourish this early embryo. So that's important role of tube. So you can understand that any damage to the tube, any blockage to the tube, any damage to the cilia or the epithelial lining of the tube, like in conditions seen with pelvic inflammatory disease and genital tuberculosis, is going to contribute to infertility, right? Now, after this, can you see here, when the morula is the 8-celled morula, when the morula becomes an 8-celled morula, on the 4th day of fertilization, it enters the uterine cavity and it leads to a 5th day blastocyst formation. Now, another thing important to note here, can you see this? Can you see this bright red line surrounding the blastocyst and the morula and the early conceptus and the zygote? So this blastocyst, morula and the early conceptus is still enclosed inside the zona pellucida. It's still enclosed. So that is what happens just before implantation. What happens is that the blastocyst, it is going to emerge out of the zona. So that's called as zona hatching, and ultimately the embryo, this early embryo, is going to dig its feet. It's going to bury into the endometrium, and the process is called as implantation, which begins on the 6th day of fertilization, and it gets completed by the 10th day of fertilization. So that is going to happen. Now, the important thing here is that all this while that the embryonic development and this movement of the conceptus into the uterine cavity was taking place in the second half of the cycle, the endometrium has been prepping up in response to the progesterone that is coming to the through the corpus luteum. So this progesterone was causing the secretory changes in the endometrium. So can you see here these secretory changes? They are very, very important because it is this early endometrium, you know, which is going to provide nourishment to the early embryo here. So that's why it's extremely important to have these adequate secretory changes on the endometrium. So fertile ground needs to be created for the early pregnancy so that implantation can take place. Now the important thing is, had there been no pregnancy inside the uterus, the corpus luteum would have died its natural death in 10 to 12 days. There would have been progesterone withdrawal, and there would have been bleeding. This endometrial lining would have been shed off in normal menses. But in this particular situation, now we do have the pregnancy inside. Now this early pregnancy, this early embryo releases beta HCG. This early embryo starts to secrete beta HCG, and it is this beta HCG which is going to rescue the corpus luteum from dying. See how this is all brought about. This early embryo helps to sustain itself. It is this early embryo which secretes beta HCG. It is this beta HCG which is going to sustain the corpus luteum in the early pregnancy, in the first 10 weeks of pregnancy till a placenta develops and takes over, right? So that's extremely important to note here, that the corpus luteum is going to survive. Increasing amounts of progesterone are going to be synthesized, and that is going to convert this endometrium now into a specialized endometrium of pregnancy that's called as the decidua. So all of this goes on once the pregnancy has been achieved. Implantation has to take place, and that is it. That is when finally the pregnancy is going to be achieved, and that is when we will be able to see this pregnancy on ultrasound and we'll say, yay, fertility achieved, pregnancy achieved. Now the important point to note here is that any damage to endometrium, causing scarring of the endometrium, which interferes with the buildup of the endometrium, any lack of adequate hormonal support in the form of an inadequate corpus luteum, inadequate production of progesterone, is going to contribute to infertility, mind you. Now let's talk about the infertility in general. What is the definition? When we say the medical definition of infertility, we say infertility is defined as inability to conceive after 1 year of regular unprotected intercourse, right? And the other important thing to note here is now, what are the causes of infertility? What is the overview of causes of infertility? So like I told you that there can be various causes. We've gone through the aspects of fertility. So in the female is the cause of infertility in near about 40 to 55% cases. Male is the causative factor in infertility in about, not far behind, about 40% cases. And maybe sometimes we land up also in situations where we are not able to identify any abnormal factor with the male and the female, and then we call it as an unexplained infertility in about 10% cases. In the female, the causes of infertility could be ovulatory dysfunction, ovulatory disorders, anovulation, so that contribute to 30% of the cases. So it is the most common and the most reversible form of infertility, indeed the most treatable form of infertility. Tubal factors follow behind by near about 20 to 30% cases are tubal causes. We can have 15% cases uterine causes, and lastly cervical causes can be there as causes of infertility here. 5% can be cervical causes. Now ovulatory causes, common causes of anovulation, PCOS, hypothyroidism, hyperprolactinemia. Tubal causes of infertility, the common ones like pelvic inflammatory disease, tuberculosis. Genital tuberculosis is one where tubes are damaged. Uterine causes of infertility could be like Asherman syndrome, submucosal fibroid, cervical stenosis, endometritis, inflammation of the endometrium. Anti-sperm antibodies are one of the cervical factors that have been implicated, something that we don't really investigate for, and we don't have really very effective ways of treating it. Moreover, they are uncommon causes of infertility anyways. And one factor which we did yesterday, the whole session was taken up, endometriosis affects infertility in ways more than one, affects the tubal, affects the architecture there, affects ovum pickup, even affects ovulation. There's a lot of scarring inside in the pelvis with endometriosis. So that's one disorder which contributes to infertility as well. And of course, the male causes can be numerous, which we will talk about when we'll talk about evaluation of male infertility. I'll go about those causes in detail there. What I want to emphasize upon here is that in a basic evaluation of an infertile couple, there should always begin with a history and clinical examination. History pertaining to all of these causes that I've mentioned. So a direct history needs to be taken to evaluate for the causes here, right? Husband semen analysis should be done. It's a very simple method of testing for the male factor. All right. Testing for ovulation should be done. Testing for tubal patency should be done. And at least a transvaginal sonography should be done to evaluate for the uterine factor. So this is the basic evaluation must required to be done in an infertile couple. And sometimes what can happen is, even when we've done this basic evaluation, we might land up in an unexplained infertility, which means that there is normal semen analysis, there is documented ovulation, at least one tube is patent, and there is a normal TVS, a transvaginal sonography, saying that everything is normal with the uterus and ovaries and tubes in general. So that is when we call it as an unexplained infertility. In the subsequent live sessions, my dear friends, I'm going to be speaking about all of these evaluatory techniques. I'm going to talk about the semen analysis, the tests for ovulation, what are the tests for tubal patency, how are they used, and what can be done if they are abnormal, and what are the abnormal findings, and how do we arrive at these various differential diagnoses. So that is going to be the topic for subsequent sessions. Thank you so much. Thanks for watching. And yes, hit the bell icon for notifications, subscribe to the platform. You can use my code SHONALI and get a 10% discount on your subscription as well. Thank you so much. Have a good day. Bye-bye.